Thanks, everyone, for submitting these questions. Here's one for both, I think, Johanna and John. So, are doctors trained to work with families and do medical reviews? I ask this as a long-time family therapist. John, do you want to start, and then Johanna?
Sure. Well, as is the answer to an awful lot of questions, it depends. It depends on the medical school. It depends on in what era the doctor was trained. When I was in medical school in the 70s, we had very little of what's considered psychosocial stuff. These days, there's a lot more of that. Involving families is very much part of what we are pleased to refer to as family practice. Whether we're actually trained and taught that, sometimes yes, sometimes no. I think an awful lot of being good at what I think you're talking about in asking this question just comes from experience, or not. Some people don't learn from experience. But
I think one of the problems with medication reviews is that often a person who maybe has a number of chronic conditions is being prescribed to by several different doctors, maybe their family doctor and 2 or 3 or 4 specialists. They might get more medications when they go to the hospital if they're given more tests and see more specialists. And I don't see anyone being given the responsibility to make sure that those medications are not causing more harm than good. Pharmacists are probably more likely to know if there are problems with a medication list. And as I mentioned in my talk, if you're on 5 or more medications, you can have a review with a pharmacist, and they can send that review to your doctor if you request it, and that would be a good kind of way of trying to get your medications reviewed. I don't think it's being taught to doctors. It may be being taught to pharmacists, but I couldn't swear to that.
Okay. Next up, we'll start with you, Katie, on this one, and then if anyone has some other suggestions, we'll keep going. But how would one hire and screen for a live-in caregiver? What would you recommend? Katie?
That's a difficult one. It really actually depends on what you're looking for and what you need. It's important to get it. I find here, particularly on the Sunshine Coast, Facebook is an amazing resource. Connecting with your community and getting the word out that you're looking for somebody. You can also reach out to the local paper, and it really does come by word of mouth. And when you're interviewing somebody to come and provide lived-in care, you really want to be able to feel like you're connecting with that individual. And you can always call Home and Community Care, and we can be involved in that process with you, give you some suggestions, do a criminal record check, ask for references, and also try them out. Have them come into the home while you're still there, and watch how they provide care to your loved one.
Okay, and let me just do a plug for a few of my community partners. I know that we have representatives here today from the Caregiver Support Network, from the Community Resource Center, and we also have the Community Response Network, which is available to support the protection of vulnerable adults, folks that are over the age of 19 all the way up to 99, and available for resources. So we have some of those volunteers here today, and please go and introduce yourselves. We've provided as well, part of Katie's handout is 7 phone numbers every senior should know on the Sunshine Coast. And please, there's a whole network of kind, smart, and available people who would like to help you through this journey. Okay. Is Dr. Sloan going to be available for home support services in Sechelt on the Sunshine Coast, Dr. Sloan?
The short answer is yes, but I've just moved up to the Sunshine Coast about 6 months ago, full time. My wife and I have been going back and forth from Roberts Creek to Vancouver every week for about 10 years. I'm slowly diminishing my small practice in the city and slowly building up a small practice here. I hope to develop a bit of a team. Over, I don't know, a year or so, I'm going to gather some frail elderly people together and see if, with the team, if we can make that work, we can help some of those people. So I guess the answer to your question is yes, but there's going to be some limitations there.
Glad you do respond to calls. How will we navigate once the new folks on the block take over your role who have limits due to life and work balance? Are there services to support and respond 24/7?
Yeah, that's, whenever I talk to other doctors about being on call all the time, they always look at me as though I need to be on some medication or something, and I'm telling you, it's not that difficult. Before I started to semi-retire about 10 years ago, I had 250 people in Vancouver, and I was on call 24/7 for them, and I would get 10, 12 calls a week, telephone calls, and I would deal with nearly all of those on the telephone because I knew those people and knew them well. And that's part of the game, is if you know your patients, when somebody calls in the middle of the night, you don't always have to immediately drop what you're doing, get out of bed, go and see them. Very often you can say, look, I understand what the situation is here. Do this and this and this. I'll see you at 8 o'clock in the morning, kind of thing. With 250 patients, I would make an outside of office hours home visit about once every couple of weeks in the city. So it isn't overwhelming. And what I hope to be able to do is just bring some of my colleagues around to that kind of understanding.
Okay, to Lady Katie here. What kind of assisted living is available on the Sunshine Coast? So that your name for home care, and how hard is it to get in? Is that your name for home care?
Oh, assisted living. So at this present time, we only have one assisted living facility on the Sunshine Coast, and that is at Christensen Village down in Gibsons. In order to access Christensen Village, you need to be actually utilizing home support services and require some hands-on care needs to get on the wait list. And the wait list really has been fluctuating. Sometimes it moves quite quickly because people are concerned about getting in. So they put themselves on the list, and by the time they get to the top of the list, they change their mind and they don't want to go. So while sometimes the wait list looks quite big, we can sometimes get 5 or 6 refusals, and all of a sudden you're right at the top. So it really is anyone's guess. Can be 6 months to a year wait. And I'm not sure if there's going to be more assisted livings. I've heard rumors that there is, but don't quote me on it.
Okay, Katie, one more on your percentage of income, 70 or 80%. How do you figure that out? Or is there some information on how to figure out the funding support for home care?
Yes. So when you meet with a case manager in the home and community, that's why it's so important to have your taxes up to date and done, because we do have a form that gets filled out. And on that form, we input your information, and we actually will get your cost for home support, and your cost for assisted living and your cost for long-term care on that form. You sign it to acknowledge that the information is accurate, and then you get supplied a copy. So that's how that works.
Okay, great. And Johanna, here's one for you. Our family and healthcare team conference is not part of chronic frail patients' care. It was routine in a facility I worked in and included family members, doctors, nurses, physios, pharmacists, and patient. They worked really well. Please advise.
It wasn't usual in the facility that we were involved with, which wasn't in BC, by the way. I think it varies. There are, for instance, there are family councils for residential care facilities, and they are suggested but optional. And if I had a loved one in a care home here, I think I would try and make sure that there was an active family council and they were dealing with issues of care that weren't just how bad the food is, because that tends to be what family councils talk about a lot. One of the things that myself and a colleague did is when we were involved with reducing a program to reduce drugs in residential care, the polypharmacy risk reduction in BC, we went out to family councils and talked to them about the importance of doing medication reviews and getting people off drugs that were not helpful, in fact, might be harmful to them. The management was afraid that people were going to complain that drugs were being taken off their list and think that they were just trying to save money. But in fact, when we went out and talked to the family councils, it was totally the opposite. We could hardly get a word in edgewise because the families were telling us how hard it was to get people off the medications they thought were not optimal. So I think I diverged from the question, but there you go.
Thank you. Okay, Dr. Sloan, this is one for you. After a fall, not particularly serious, but my mother's short-term memory all but disappeared, e.g. remembered nothing of her beautiful lakefront condo on Lake Ontario or the friends she collected after her move there over 12 years before. Is this usual? Have you seen this, and any reasons why?
Falls typically don't affect mental function unless there's a head injury. And the most at-risk group are people on blood thinners. So if you have a fall and somebody hits their head, especially if they're on blood thinners for heart rhythm disturbances or any other reason, that's when we tend to image the brain and see if there's bleeding there. Now, sometimes strange things cause falls. So a person can fall because they had a stroke, which wasn't recognized in any other way than that they fell, or that they had a heart attack. There was no chest pain, there was no breathlessness, there was just a fall on the ground. They get investigated. The heart attack isn't noticed because it didn't present normally, but that heart attack in turn affects thinking. Answer to the question is the connection between fall and loss of memory, it needs to be investigated because it isn't usual. That's not usually what happens after a fall.
Thank you. Katie, maybe you can help us with this one on both home care and the Sechelt Hospital discharge team. Do you have personnel or staff to assist family to prepare home in return of a frail elderly patient? Home care staff, but also accessibility advice, like how to adapt the home care environment for that transition back?
Yes, actually. So the team at the hospital is very similar to the team in home and community care. They have a team of physiotherapists, occupational therapists, social work. And if there was concerns around accessibility in the home, what you can actually ask for is a home safety assessment. And what that will do is someone from the community, one of our OTs, would come out to your home and do an assessment of the space, particularly if someone's care needs have changed and now we're concerned that there's going to be safety risks. So they'll look at your bedroom and your kitchen and how you get into your house and give you a list of recommendations.
Perfect. And while you're at it, Katie, home and community care, is this part of Vancouver Coastal Health or is it private? And where does Better at Home, how does that program fit in? And really sorry she couldn't make it today, but could you answer that?
Sure. So, home and community care is under Vancouver Coastal Health, but there's also private agencies here that provide home support assistance in the home. We actually have a list of resources available if you want to look at services outside of the public system. And then Better at Home is a service through the community services building. So we actually live right beside each other in Sechelt, and they have a coordinator by the name of Anna, and she does the Better at Home service. So that service actually provides more housekeeping, transportation, and shopping support.
Great, thank you. Okay, Dr. Sloan, back to you. Your definition of capability and function covered and included both ADLs and IAPLs. IADLs.
ADLs, yeah.
Don't mind me. Sorry. Driving, shopping, handling finances, meal prep. Do you see a distinction? Could you redefine what those things are?
Yeah,
again?
that's interesting. We talk about the basic activities of daily living: dressing, eating, walking, using a toilet, grooming. And then there are the so-called instrumental activities of daily living, which generally speaking take place outside the home: shopping, maintaining the domicile, banking, food prep, transport, med management. Those activities of daily living tend to fall in a certain sequence, like dominoes. So financial management and getting around the community independently, like driving a car, would be very early ones to be affected with dementia, mobility problems, and so on. One gets into the basic activities of daily living at about the same time that the person becomes effectively homebound, so that it's just impracticable. You can move anybody anywhere with an ambulance, but in people who we call homebound, it's just impracticable for them to get out and see a physician in the community. Bathing is usually the first of those to go. Very, very impaired people in residential facilities are referred to by staff as a feed if they actually have to be fed, and that's usually the last one to go. So there's kind of a sequence of complexity in those activities of daily living. None of us is 100% competent at doing everything. We can't necessarily fly airplanes or even do our income tax, but gradually as dementia sets in, gradually as mobility problems worsen, people do less and less. And I don't know if I've addressed that.
So group homes, the Sunshine Coast, they're all full. It can take over a year to get in. What does one do if one cannot function alone? Katie, any suggestions?
Gosh, it's so complicated. Really, your first step is to get in touch with home and community care and get a case manager out into your home. And they really take the time. A good assessment from a case manager typically takes about 2 hours, and they go through everything. They will talk about what your wishes are. They will talk about how you're functioning. They will talk about who are your informal support systems. They will talk about how you have managed day to day up until this point. And then they will look at what the areas of concern are and how to put in some support. Ultimately, there are times when people don't have any support network and they're just failing, and there is the ability to put someone on a list to go into placement on an emergency basis. So you can actually bypass the wait list and go to the top when you're in a very unsafe and high-risk situation.
Yeah, I think loneliness and isolation are terrible things, and they're things that we often just don't recognize in our kind of medical lists of problems. And you know, some people are just naturally social, and they make contacts. They have what we think of as a circle of care. Others kind of keep to themselves, and it can be very, very difficult to effectively help somebody who is isolated. So it's a big problem in our practice, a difficult problem. All you can say is, for goodness sake, try, if you can, within your own personal resources, to reach out and make contacts and be friendly with other people, because they can be a big help.
I belong to an organization called the BC Rural Health Network, and we're looking at the problem of isolation, which is a big problem in rural communities, and it's absolutely twinned with transportation. One of the big problems is that when there isn't adequate public transportation, people become more isolated because they can't leave unless they can drive. So I think those two things go together.
Okay, thank you so much, panel. You did a fantastic job today, and we're really lucky to have you all now in community.